right, good afternoon, everybody. I'm Jessie Werner, and I met a lot of you yesterday. I'm very happy to be back talking to you this afternoon about rapid sequence intubation. And I'm going to start with a story. We all know that this is a really important topic. This is one of the most exciting procedures that we do, but also one of the scariest. And when I was a resident, I'll never forget this, I was a resident, and one of my senior colleagues, I was a junior resident, senior resident, was dealing with a patient who had angioedema, the feared angioedema. And they had tried a number of different interventions, hoping that they would be able to reduce the swelling and not need to take this patient's airway. And it didn't work, wasn't working. And they realized that they were going to need to intubate this patient. So they used RSI, and the resident went in to take a look with direct laryngoscopy, and just no view. Nothing, just swollen, edematous, everything. And I remember the attending was at the bedside, starting to look a little nervous. The resident was looking nervous. I was just happened to sort of be in the room. This was in our critical care bays. The tension just immediately rose. You know, he switched out devices, tried to look, was having an incredibly difficult time looking. And remember, this patient is now paralyzed, not breathing at all. He has no assistance from the patient in breathing. Could not get a view. Ultimately, this patient actually had to get a crike and did okay, but this is why RSI is scary, because we are paralyzing the patient, we are taking away all their airway reflexes, and we're not sure what we're going to see when we get in there. We have no guarantees that this is going to be a successful or easy intubation. So it shouldn't be taken lightly, but there are things that we can do to optimize our success. So we're going to talk a little bit about that. So in this talk, we're going to talk about the concepts of preoxygenation in RSI. And this is everything. Preoxygenation is what is going to lead to success when you intubate your patient. And ultimately, with the patient I just spoke about, the patient with angioedema, the reason they had so much time to try a different device and ultimately to move to crike, which also was not quick, is because they had successfully pre-oxygenated that patient. And that gives you a lot more time to try and get that airway before they start to desaturate. We're going to talk about the evidence of cricoid pressure and pretreatment drugs. And I can just kind of break the news to you right now that neither of those are good. And we'll talk more about that. And then we're going to talk about post-intubation sedation and analgesia. This is the other incredibly important part of intubation. And believe it or not, even now, we're not great about sedating our patients after we intubate them. And I'm going to talk to you a little bit about that. It's so important. So this is obviously our goal. This is what we're shooting for. It's the glottis and the cords, and that is what we want to throw our tube through. So talking about RSI, rapid sequence intubation, what exactly is it, and how does that differ from what we've heard, delayed sequence intubation? So the concept behind RSI is actually developed by anesthesia. So the traditional approach that anesthesiologists use when they're intubating a patient, traditionally, was they would push a sedative, bag the patient, push the paralytic, bag the patient, take the airway. That is not RSI. That was the traditional approach. With patients who were healthy, the idea was that this was going to be a pretty easy airway. These patients had good reserve. They were not critically ill. But then they started taking care of patients who were critically ill, did not have good reserve, perhaps had bowel pathology, perhaps were extremely obese. And they started to realize that they needed another approach to help with the idea of gastric aspiration, regurgitation, and then aspiration. The gastric contents coming up while they're trying to intubate, and then the patient aspirating and leading to complications. And that is where RSI came from. So they developed the RSI technique, which essentially is pushing the sedative and the paralytic in sequential order at the same time. And the idea behind it is and the reason it was developed is that ideally it will lower the rates of aspiration and gastric contents coming back up and then the patient aspirating. And part of RSI is that you do not perform manual ventilation until you take the airway. So you push the sedative, you push the paralytic, you do not bag the patient because, again, you don't want to cause gastric contents to come back up, and unless the patient is hypoxic. If they're super hypoxic, you can bag them, but generally you don't want to be bagging them, and then you take the airway. That was how it was sort of traditionally developed. But then, of course, they started to realize that patients who were not getting oxygen before RSI were not doing very well. They didn't have a long time to take that airway, and these more complex airways made it really challenging. So when we're just breathing room air, that's 21% FiO2. And what they found is even in healthy patients who are just breathing room air, when you go to take that airway, you have less than 60 seconds, really. You have less than 60 seconds if they're just breathing room air. And that's not even a patient who's critically ill. So they realized, you know what we need to do? We need to pre-oxygenate these patients so that we make that safe apnea time much longer. And the safe apnea time is the time from pushing the paralytic to when that patient desaturates, or basically gets to 88 or 90%. And what you realize is that when you pre-oxygenate a patient, that time to reaching 88 or 90% becomes much longer. So we're going to talk about that. Again, this is the rationale behind RSI. So emergency medicine, every patient that we're intubating, for the most part, I mean, they haven't been fasting, they may have full bellies, many of them are critically ill, that's why they're getting intubated, they may be full of gastric contents. So we adopted RSI from anesthesia because we're like, that's every patient that we're dealing with. And we want to limit the amount of gastric contents coming back up and aspiration. So we're going to do RSI. And the pros were that it was thought to reduce aspiration. Ideally, we would have higher rates of success because when you push the paralytic, then you can get your view, the patient's not struggling, it will facilitate intubation. When you are paralyzing the patient, you're taking away some of that catecholamine release that leads to increased blood pressure and increased ICP from manipulating the airway and intubating the patient without a paralytic, and that you would get better C-spine control because you can be really careful with the patient. But the things that you have to watch out for with RSI is what I kind of mentioned, which is that when you go in there, you don't know what you're going to see. And some of these airways are not easy. So sometimes you end up with a prolonged intubation that you didn't necessarily plan for. You may have some adverse events from the medications that you're pushing. And in the worst case scenario, you've got a crash airway. The patient's coming in, they're very, very sick, you need to take the airway immediately, you RSI them, you're not sure what you're getting, it could be a messy situation, sometimes it goes to crike. So it's in some ways a little less controlled than something like a delayed sequence intubation, which we're going to talk about. So here's the idea behind RSI. You prepare, you're pre-oxygenating your patient. Pretreatment is actually out. In the past, there was pretreatment. It was thought to sort of help with some of the effects of intubation, that perhaps we could help with the increased ICP, that we could give them things to help with their response to the medications, but actually that has been shown to not be very effective, so we don't do that anymore. At time 0, that is your RSI, that is your paralysis and induction. Then you can position your patient, you place your tube, and you manage them afterwards. So we're going to talk about these. Preoxygenation. Preoxygenation is everything, and denitrogenation is everything. So what does that mean exactly? There's lots of different ways to preoxygenate the patient. We're going to talk about that. But in addition, part of the goal is taking away the nitrogen so that when the patient exhales and they have that residual capacity in their lungs, it's the amount of air that's left in your lungs after exhalation, the goal is to replace all of that with oxygen. And so they have this huge oxygen reserve. And that's actually, when we're talking about sort of where our oxygen reserve comes from, 95% is from the lungs. Only 5% is from the blood. So really, we want to oxygenate those lungs, take out the nitrogen, replace it with oxygen. And this is part of why it's so important. So you can see the oxygen saturation here on the vertical line, and then we have our arterial oxygen saturation. And what I want you to focus on is the SaO2 of 90%. So when that pulse ox is about 90%, that person's PaO2, their arterial partial pressure of oxygen, the oxygen in their blood, is about 60. They are about to drop off of that cliff. So anything less than 90% on your pulse ox is worrisome, and they are about to drop off the cliff. And so we want that SaO2 as high as possible, definitely higher than 90, and as close to 100% as we can get it. Now, this was a study where these were not ED patients. This was done by anesthesia. They took patients who were pre-oxygenated, they pushed succinylcholine, and they waited to see how long it took them to desaturate. So this is not our ED population, right? These patients, for the most part, you had time to pre-oxygenate them. And that is why you'll notice that the lowest amount of time for someone to desaturate on this graph is 4 minutes. We don't usually have 4 minutes, even with the patients that we've pre-oxygenated very well. So what you should take away from this is what I have starred here, which is that a normal, healthy adult will do significantly better, and this doesn't take a rocket scientist to figure out, than someone who is ill or obese or a child. And so not everyone is the same, and this can vary greatly. So in this study, a normal, healthy adult did not desaturate until 8 minutes. Now, again, this is not an ED patient, but they were pre-oxygenated properly. They had 8 minutes. The moderately ill adult had about 6 minutes. The child had a little more than 4, and an obese adult had the least amount of time. They desaturated at about 4 minutes. So just keep in mind that depending on what patient you're intubating, you are going to have less time before you need to make sure that you successfully secure that airway. This is a wonderful paper. This is like the paper on pre-oxygenation. It's by Rich Levitan and Scott Weingart, who are sort of the fathers of critical care medicine and the fathers of airway medicine. I recommend everyone read it. It's available for free in the Annals of Emergency Medicine. But basically what they did is they were looking at the utility of pre-oxygenation and how it can prevent desaturation when you're taking an airway. So let's look a little bit closer. They basically risk stratified their patients, and then they did various interventions to try and pre-oxygenate them optimally. One thing that they did for every single patient is this apnic oxygenation. And so the idea behind apnic oxygenation is you have pushed your sedative, and you have pushed, in some cases, you've pushed your paralytic. The patient is not breathing. You've pushed your paralytic, the patient is not breathing. And during that time, while you're trying to get the airway, they're paralyzed and you're trying to get the airway, you want to continue oxygenating the patient. And so what they did is they put nasal cannula on the patient and they turned that wall monitor up to 15 liters. And they kept the nasal cannula on throughout the entire intubation. And they found that that gave them more time to get that tube in. It gave them more time before the patient desaturated. And so their recommendation, and what a lot of people now recommend, is that you always intubate with nasal cannula on. You keep that nasal cannula on, you turn the wall O2 up to 15 liters per minute. It's gonna be high, it's gonna be hissing, it's gonna be annoying to everybody in the room, but that will give you more time when you are taking the airway. And now, part of the reason when we put nasal cannula on patients who are awake, part of the reason we only turn it up to 4 is because it's uncomfortable. It's, drying and severe. It's uncomfortable. Patients don't tolerate it. But remember, this patient is sedated. They're paralyzed. They're not awake. So crank that baby up. And they found this to be incredibly helpful. Gives you more time when you're taking that airway. The other thing I wanted to say about that is even during apneic periods, when the patient is not breathing, so your diaphragm does not even need to be moving, you still have oxygen moving into your alveoli. There's still diffusion of oxygen. So that's what this is doing. This is taking advantage of that physiology. And here's the idea behind it. Nasal oxygenation during effort securing a tube. In case you need help remembering it, they created a little acronym here, no DSAT. But I think, it's very easy to remember. Throw the nasal cannula on, keep it on while you're intubating. And the other thing to remember is nasal cannula can go under your other preoxygenation devices. So a lot of times what we're using to preoxygenate these patients is a non-rebreather. You don't need to use that alone. You can put the nasal cannula on underneath it, put the non-rebreather on top of it, effectively preoxygenate that patient, push the paralytic, take the non-rebreather off, keep the nasal cannula on, and take the airway. And you will be doing yourself a favor. You give yourself a lot more time when you're taking that airway. Now, this is DSI. This is delayed sequence intubation. And where did this concept come from? So basically the idea behind this is that we have patients who come into the emergency room who just cannot tolerate being pre-oxygenated. They're just resistant to it. They may have, altered mental status. They're pulling things off. They're agitated. And so you're not getting effective pre-oxygenation. And so in that case, we already know you don't want to push the sedative and the paralytic if you haven't pre-oxygenated your patient because you have no time. You have less than 60 seconds. So you need to pre-oxygenate. How are we going to do that in this patient population? The answer is DSI, delayed sequence intubation, where essentially what you do is you push a sedative like ketamine, where the patient maintains their airway reflexes. They continue breathing, they continue helping you. You help them to be calmer. It's a little dissociative dose of ketamine. In this study, what they used was 1 mg per kg. If they needed a little bit more, they would push by 0.5 aliquots, so 0.5 mg per kg aliquots as needed to increase it until they felt that the patient was dissociated and comfortable. Then they pre-oxygenated the patient in whatever way they needed to, with a non-rebreather mask and nasal cannula. If they were desaturating, sometimes they used an assistive device like non-invasive, like CPAP. Sometimes they needed to use a bag valve mask with PEEP device. They pre-oxygenated the patient, they got those O2 sats up, then they paralyzed the patient and took the airway. So the difference is with delayed sequence intubation is really just the timing of the sedative and the paralytic. Rather than pushing at the same time, there's a little bit of delay. You push the sedative, you dissociate the patient, you pre-oxygenate them, then you push the paralytic when you're ready. And so here's that paper again, this wonderful article where they're talking about the importance of pre-oxygenation, and they basically risk stratified their patients. They had pre-oxygenated the patients with a non-rebreather, and they looked at their SATs. And they said, okay, people who are doing well, who are responding well to this pre-oxygenation, they're low risk. They're SATing 96 to 100%. Those are my low risk patients. When I pre-oxygenate them, I'll just keep that non-rebreather on. And what they found is, again, go to the wall, don't turn it up to 15, keep turning it up. Keep turning it up because you can actually increase the FiO2. So a normal non-rebreather in the ED, sometimes we call them non-rebreathers and they're not actually non-rebreathers. The reservoir should just have fresh oxygen in it, and it should not allow the patient to exhale back into the reservoir. There should be a one-way valve on there. Not all of our non-rebreathers in the ED are like that. So sometimes it's not reliable. Sometimes they are breathing their own exhaled gases. The other thing is it should have one-way valves on the mask, so all they do is exhale out and don't breathe back in their CO2, but not all of our devices in the ED are reliable in that way. So check and see what you're using. But regardless, even with with a good non-rebreather, the best FiO2 you can get is about 60%. Now, we always say, oh, it's 100% FiO2. That's not actually true. It's more like 60%. So you really need to go to the wall. What they found is if you go to the wall and turn it up past 15, turn it up, just keep cranking that puppy up, the calibrations will not say any higher than 15 liters, but actually you're getting more like 30 liters, and the FiO2 will be closer to 90%. So when you're pre-oxygenating a patient with a non-rebreather mask, go to the wall and crank that puppy up past 15 liters. Just keep going. That will increase the FiO2 that the patient's getting, and you'll get better pre-oxygenation. So that's for your low-risk patients. Then they found these high-risk patients and these hypoxemic patients. And what they did for them, the way they established this, is again, they had them on nasal cannula or a non-rebreather. They tried to pre-oxygenate them, and these patients would just not raise their SATs. Their SATs were just not going up past 91, 95. Some of them were truly hypoxic. And what they realized is these patients need some PEEP. We need to pop these alveoli open. We need to better oxygenate them. They needed some positive pressure. And so what they did is they used a CPAP device or a bag valve mask with PEEP to give these patients a little bit extra. And they found that that usually helped to increase their pre-oxygenation and their SpO2 before they went towards intubation. Some patients, it's still not going to work. You might put them on CPAP, or you might be BVMing them with a PEEP valve, trying to get them up, and their SATs will not go. And so if it's unsuccessful, unfortunately, you just have to go ahead and take that airway. But this is how they sort of risk stratified and how they decided what they were going to use to pre-oxygenate those patients. So people with pretty good SATs, non-rebreather is fine with a nasal cannula underneath. Fine. But people who have lower saturations, consider some positive pressure. And this is the PEEP valve that we place on our BVM. These are your oxygenation options. You guys already know this. Nasal cannula. Don't use a simple face mask. Those are not good. They don't have an oxygen reservoir. They mix with the 21% air FiO2. You're getting all this mixed oxygen. It's not a good thing. Just get rid of the simple face mask. What you really want is a non-rebreather, ideally a true non-rebreather. And then you can always use something like BVM, bag valve mask, or CPAP. What about pretreatment? I kind of pointed out to you that a lot of studies have pointed us away from this, and that's true. That's true. We're no longer doing this pre-treatment anymore. So like the defasciculating agents, we thought that when we pushed sucks that it was going to be a real problem, that the patient has some muscle fasciculations, and we wanted to give them some more more paralytic on top to stop the muscle fasciculations, and lidocaine for increased ICP, and that just didn't pan out. It's not proven to be helpful, and there's really no indication for using these pre-treatment drugs. Let's talk a little bit about paralysis and induction. First, paralysis. What are our choices? Usually, we're going to use sucks or rock. Those are the big things that we're using to paralyze the patients. When we're talking about succinylcholine, the dosing is 1.5 mg per kg, takes about 45 seconds, lasts 5 to 10 minutes, does not last long. Of course, we know there's some contraindications that we need to be aware of with sucks. With rock, you can generally use 0.6 to 1.2 mg per kg. It's easy just to remember 1. Takes a little longer to act. So you're going to need to watch the clock, wait for about 60 seconds to pass before you try and take that airway. This lasts 45 minutes. Whoa. That baby lasts for a long time. Now, there's some advantages, because if you're going to take multiple attempts at that airway, you want that patient paralyzed, and you want to have time to do it. And actually, the paper that I keep referring to, rock was found to be superior. They actually found that people did better with less desaturation when using rock. So there does seem to be some advantages. And there's few contraindications. You don't have to go through your mindset as much of, oh, does this patient have severe burns? Are they hyperkalemic, like you do with succinylcholine? What about induction? So there's 3 main ones that we use. Etomidate, 0.3 mg per kg. It's very rapid onset. It may cause hypotension, but really it's pretty safe and pretty fine to use, and I actually love etomidate. But remember, there's no analgesia with etomidate. Propofol is another option. Of course, the big side effect there is hypotension. And of course, patient has respiratory depression. There's also no analgesia with propofol. Then we have ketamine. So 2 mg per kg, onset is pretty quick. This is a really nice one if the patient does have low BP, and this is what we use in traumas all the time. The thing to remember about this, let's say you're using etomidate, propofol, ketamine, all of them, they don't last long. How long did I just say rock lasts for? 45 minutes. Etomidate wears off in, less than 10. So then you've got this patient who is paralyzed and not sedated. That is my worst nightmare. That is your worst nightmare. That's your worst nightmare for anyone you love and care about. To be lying there, paralyzed and awake. Don't let that happen to your patients. We're going to talk about more that in a second. What about positioning and protection? Of course, when you intubate a patient, positioning is very important. And it used to be thought that an obese patient was the only one that we needed to sit up a little bit, to ramp. Only the obese patients, but actually it's been found that it's beneficial for everybody. So sitting them up at about 20, 30 degrees can be really helpful. You can do a little reverse Trendelenburg if you're worried about C-spine precautions. You can do a little ramping. It's helpful for everybody. In terms of protection, this was where we used to apply cricoid pressure because we thought that if we kind of push down on the cricoid membrane and the cricoid cartilage, we could occlude the esophagus and prevent gastric contents from coming back up during intubation. Not useful, not helpful, doesn't pan out, we shouldn't be doing it. And in fact, they found that a lot of times all you're doing is making your own intubation harder. It occludes your views. So cricoid pressure is out, okay? And this is a paper saying exactly what I just said. One thing you can do if you're trying to optimize your view is bimanual laryngoscopy. And essentially what that is while you are looking and you have the laryngoscope, surgeons always say, hey, we have 2 hands for a reason. Use them. Use both of your hands. And I love that. That's so true. It's true for every procedure that we do. It's true for intubation. So when you have your laryngoscope in, don't forget you have another hand. You can slide that under the patient's head. You can manipulate the head to improve your view. But technically what bimanual laryngoscopy is you take that hand, you put it over the tracheal cartilage, okay? And then you manipulate it until you kind of improve your view. And that's when you find it and you say to your assistant, can you please put your hand exactly where my hand is? Or you take their hand and you physically put it there. And they hold it and you've got your view and you go for it. So that is what bimanual laryngoscopy is. But it's not cricoid pressure. So post-intubation management, sedation and analgesia. This is such an upsetting paper. So essentially what they did is they looked at patients who received succinylcholine, and they looked at patients who received ROC. And then they looked at the time it took those patients to receive analgesia and sedation after they got paralyzed. And here's what they found. The patients who received rocuronium, the time between intubation and sedation was 27 minutes. And the patients who received succinylcholine, the time between intubation and sedation was 15 minutes. Now, neither of these is very good when we think about etomidate wearing off in 10, but ROC in particular is awful. 27 minutes. So there does seem to be a correlation between using rocuronium and not giving sedation for our patients. And I think it's because the patient's not moving. They're quiet. They're silent. Our team is very busy. And so you think, oh, they're quiet. They're silent. They're not moving. Everything's fine. They must be comfortable. No. Please don't forget to sedate your patients. Please don't forget to give them pain control. Even when they're paralyzed, they can feel pain and they can feel fear. I had a nurse come grab me when I forget when this was. She came and grabbed me and she said, something's not right. The patient, his heart rate just went up. He's really tachycardic all of a sudden. He's hypertensive. I'm not sure what's going on. You go into the room. The patient's tachycardic. He's hypertensive. He has tears in his eyes and he's paralyzed. This patient is not sedated. That was the problem. Not sedated. Said, turn up the propofol. Sometimes our team gets scared, and they're scared to turn up the propofol, and the propofol's at 5. It's doing nothing. Turn up the propofol. The patient is not sedated. If you need to use pressors to help augment that blood pressure while you achieve proper sedation, do it. Give them some pressors, give them sedation. It's just so awful to do to a patient. And don't forget that paralyzed patients can tear. They can cry, and you will see tears in their eyes. So that is a huge takeaway. Make sure your patient is sedated. Go back and check. Once you've intubated the patient, don't forget to check that the tube is in the right place. And capnography, end tidal CO2 is really the gold standard. So a lot of times we'll say, oh, I see, I can see condensation in the tube, or the chest x-ray looks good. None of that is true confirmation. End tidal CO2 is your gold standard. So that's a review of everything we just talked about. Thank you so much.